Good morning again, and good evening to those of you who are joining from the other part of the world. So it's a great pleasure and honor to welcome all of you to this event where we are launching the Global Observatory of COVID-19 vaccine incentives, as well as having an information sharing session on this concept as well as the technology behind that. So it is really an important area of discussion that we are trying to engage in the next 2 hours. So I really thank all of you for taking your time off for joining this. I'm Novil Wijesekara. I'm a Hubert H. Humphrey Fellow at the Hubert Department of Global Health at the Rollins School of Public Health, Emory University, Atlanta, Georgia. I'm from the Disaster Preparedness and Response Division of the Ministry of Health, Sri Lanka. Along with me, we have two distinguished speakers today. One is Dr. Este Geraghty. She's the Chief Medical Officer from ESRI. I don't need to introduce her. She's a well-known speaker and an expert in public health and GIS. So I warmly welcome her. We also have a very important speaker, that is Dr. Karen Beardsley. She's the Director, Global Professional Programs and Humphrey Fellowships Program at the Global Affairs, University of California, Davis. So what we will have today is we will have two presentations. First, we will have the presentation by Dr. Este, and then we will move on to a presentation by Dr. Karen Beardsley, and then I will have the small session on the observatory, and we will go for question and answers after that. So we will be recording this session, so we would be able to share it with the others who could not participate. And also we would be taking some screenshots with the participants for sharing in our social media and other platforms. So we love to have you there, but if you don't want your beautiful face to appear there, just let us know in the chat. So we will have a smiley in front of your face in the collage that we are doing. Okay, with that, I won't take much time. I am so grateful to have Dr. Este Geraghty from the ESRI. She's the Chief Medical Officer there. She has vast knowledge and experience in the public health as well as in GIS. I'm not going to read her bio because it's very long, and I invited her to tell her a little bit about herself during the presentation. So without much ado, over to you, Dr. Este.
Thank you so much, Novil. I appreciate that. And you're right, bios are just too long nowadays. We're all involved in so many different things. But by way of introduction, I am an internist by training. And in fact, I did my internal medicine or my medical school training at UC Davis. And also my master's degrees in public health and in health informatics. And that is how I got to know Karen Beardsley. So she and I have been acquainted for many, many years. So this feels like a family discussion in many ways. But it's been about 7.5 years since I came to ESRI. And it's just really brought all of my interests together, that technology piece and the public health and the healthcare piece. With GIS, bringing it all together to help health organizations of all kinds around the world do more with this technology to support all of our health needs. And, you know, I would say that GIS in health has really received a tremendous amount of attention over the last 2+ years in particular. As you all know, I think it has been used by governments, academics, nonprofit organizations, and healthcare organizations of all kinds. and for various purposes. But in this short presentation, I want to share a few of the most common applications of GIS for pandemic response. And I hope as I do this that you're going to recognize that these same kinds of workflows can be easily adapted to almost any kind of health workflow that we need to do. So it's certainly relevant to future preparedness needs, but also to other kinds of health challenges that we face in communities around the world. So the way that I'll approach this is by covering 5 key areas of applied GIS, starting with map-based situational awareness. Then I'm going to highlight some key analytics and site selection methods that help us to improve our planning with that all-important emphasis on equity right at the center. And then I'm going to show how GIS has been applied to connect people to the resources that they really need, and also to communicate up-to-date information with the public. So let's dig in. There's no doubt that people have been getting their pandemic-related situational awareness from mapped data. So let's start with this evidence. I wanted to begin by making a few points about the importance, not just the existence, but the importance of the Johns Hopkins University COVID-19 dashboard. This has been the most viral map-based application in history. It has several trillion views. None of my Facebook posts have that. First, I would say this dashboard, it has awakened the world to health GIS in obviously a pretty dramatic way. And the Johns Hopkins team really prioritized data sharing. And that was a huge enabler for thousands of organizations to be able to visualize and analyze, plan, and make better decisions for their own local COVID-19 response. Now, furthermore, I would say that the Hopkins data, on maybe the unfortunate side, exposed gaps in our data collecting and our data sharing and interoperability methods, or even that it existed in some places. And I would say that that magnification of the gaps has been so profound that I believe we're all going to see real solutions on the near horizon. And finally, the dashboard, because of its regular updating, started to really build these expectations among all of us to get real-time or near real-time data. That too is going to change us. Those of you who are already in health may know that that's been pretty unusual. Now, again, because of the open data sharing, others could just consume that Johns Hopkins data, and they created thousands of similar kinds of dashboards that, again, provided that near real-time data for very localized situational awareness. And at ESRI, actually, we were also enabled by the JHU data. So for example, this map is showing the weekly case rate trends, where gold indicates improving rates and purple signifies worsening rates. I took these just a couple of days ago on the 15th. So again, gold is good, purple is poor, and you might look at this map and say, things are great, we're doing really well. And I wholeheartedly would say, yes, there is a positive trend that most of the US anyway, and you could look at this from other points of view, are doing well. The trend is downward. Okay, but that improvement trend needs to be seen in context. It doesn't necessarily mean things are good. It only means things are improving. So right direction, but not good enough. And that's where this ESRI map comes in. Here, what we are seeing is where each county is sitting in terms of pandemic phases. And pandemic phases were outlined by the World Health Organization, giving you a case rate per 100,000 people, and then determining if that fits into an emergent infection spreading epidemic, which is the worst stage, or if it's getting better to controlled or end stage. So you can see that most of the country is still in epidemic trend by a long way in terms of case rates, just by the way. Some, obviously, because of the last map, are doing better within the trend, but it's not over. I know there's a lot of news out there right now talking about being in endemic phase and that things are getting better, and better does not mean good. So everything in context, and maps can do that. And I like even this higher level view with this map that we call COVID Pulse. And this is a visualization technique using spark lines. And those are the lines that are really displaying for each state, in this case, the whole history of the pandemic. These trends are normalized, so it allows you to see and compare one place to another. And if you zoomed in on this map, you would see the same information by county. So you can really catch the differences of what's happening place to place, which is part of why geography is so helpful, because it is actually different. Now, situational awareness certainly goes well beyond the Johns Hopkins data, of course. Here, what you're seeing is the Africa CDC. They've been sharing situational awareness around the vaccine delivery, many different vaccine brands being used across the continent, and the different variants of concern. And then the state of Missouri is just one example among many that's testing their wastewater for viral shedding. You may be seeing a lot about this in the news lately. This is really the latest surveillance trend. But when the viral shedding is detected, it becomes an early surveillance indicator, giving us anywhere between 2 and 14 days advance notice of an upcoming surge. And in fact, the state of Missouri is also able to tell which variants are in the wastewater. So you not only know increasing or decreasing trends, but you know variants of concern and when they're starting to spread. It's nice because that's passive and inclusive, at least for those on municipal wastewater systems. So map-based situational awareness definitely gives us the lay of the land. The spatial analysis then provides stronger evidence that we need for planning and decision-making. And of course, if you want to do great analysis, you really need great data. One of the recent innovations, at least recent during the pandemic, has been the availability of anonymized and aggregated cell phone data. And that comes from organizations like Unicast and SafeGraph and others. And their data really revealed social distancing behaviors and even the visitation rates for businesses like grocery stores and gas stations and home improvement stores. In fact, that's how we knew in the US that people were spending their initial isolation times doing home improvement projects because there was high visitation rate to those stores. And this kind of information really gave great insight into human behaviors that could be useful for guidance and policymaking. And so remember that social distancing behavior data, because it was used in many ways. It supported enhancements that we at ESRI made to epidemiologic models like the CHIME model. And those models are meant to simulate viral spread. So the geographic lens of this helps you account for that spatial variability in the social distancing behaviors and also in disease spread, which then allows you to make more accurate predictions for which regions or which hospitals would be more impacted by COVID-19 cases, when that surge was going to happen, and how long the surge might last. Super important for capacity planning. And then again, the same anonymized cell phone data was used to estimate the rapidly and dramatically changing demographics happening in many hospital service areas. And that was allowing leaders to make more effective plans or adjust their strategies in the near and the long term. And I really love this last one showing that same information. This is an analytical application that looks at social distancing and weather. So here we're using space-time cubes to show social distancing over time by county in California. So a blue area is an A grade of social distancing, doing really well, and the red is an F grade. So we put in that time of when the California stay-at-home order went into effect. You can see coastal counties actually did really well with social distancing, whereas Inland counties certainly improved over baseline, but did a little less well. But then at the end of April, something happened. People started gathering at the beaches, but the policy had not changed about trying to stay at home. So why did that happen? Well, we pulled in weather data from NOAA, and you'll see that come up in a moment, and we could build that weather data up over time so that it matched the social distancing behavior over time. We call this a voxel layer. Voxel is like volume and pixel put together. So now you can see in the brown, yellow areas, that's where the weather is warmer, or the time period when the weather is warmer, and the blue and green areas are cooler. Now you can compare face-to-face social distancing behaviors and weather. So let's zoom in on San Bernardino County. That's where ESRI headquarters is. And you can see very clearly that there's a strong correlation between warmer weather and worsening social distancing behaviors. Pretty interesting information. And again, insight that helps you guide policies and deliver risk communication messages. Okay, switching gears a little bit, another interesting example of analytics is using GIS for contact tracing. Now, in ArcGIS Pro, you can do link analysis, and that helps you to better understand person-to-person connections. Of course, that is the traditional methodology behind contact tracing. But in addition, what you can do is apply tools from graph theory, like centrality, and that helps us to determine the strength of person-to-place connections. Now, when you do this, you would do it in this exact situation where we have community spread or community transmission of disease. And now you can start to understand where are the highest risk places. Now, throughout the pandemic, we've needed to stand up new resources in communities across the globe. And as it turns out, the whole workflow of site selection is a really common and a high value use of GIS. Now, we built a tool that performs the workflow of site selection in a simple and automated way so that you don't have to know all of the ins and outs of the technology. You can just sort of be guided through it. And so I wanted to show you this example that's focused on increasing vaccine coverage. So this begins by first just collecting all of the community's existing vaccine locations. Of course, there are probably things like pharmacies and community clinics and hospitals. And why did that go that way? Okay, must have hit the wrong tool. Anyway, then the user has to specify the geographic area that they're interested in, right? I mean, that could be a country, it could be a region, a city, a village, or even a customized area that you're interested in. Now, next, what the user does is they make a determination about what is an acceptable level of access to any community vaccination site. Now, depending on your geography, it might be 30 minutes driving time, or it could be 15 minutes of walking time, or whatever else makes sense for that place. Now, once you've input that, the very first calculation that the system will do is estimate the percentage of the population that can actually reach a current vaccination site in the time you suggested. Now we need to work on the gaps, right? So those are the places where people didn't have good access to the vaccine in that time frame. So we begin by adding in candidate vaccination sites, and those are shown here in gray. Those could be parking lots for pop-up clinics or drive-through clinics. It could be blood banks or schools or convention centers or any other place where vaccine administration could logically take place. So then we want to add some more elements of equity that go beyond that geographic accessibility that we already accounted for. So here we include any and all factors that are relevant for this specific population. It could be having availability of clean water for hand hygiene. It could be anything. In fact, let me show you a few of those attributes. And they're basically put together as a weighting factor in the final analysis. So here are some examples of vulnerabilities for COVID-19. I think we're all getting pretty aware of these, but we know that some people have increased susceptibility to severe disease. They might have factors that put them in a position to be more exposed to the disease based on their jobs or their living situations. Or we can include various socioeconomic or sociodemographic risk factors like race or vehicle ownership, language, anything that seems to be a relevant indicator of vulnerability that you want to include. So once you put all of your factors into the map, you simply run the tool, and in the end, it will select the fewest of the candidate locations that would be needed to close the geographic gaps while favoring the places that had the highest vulnerability. So lots of things going on there, but it makes it much easier for decision making. So once you have stood up new resources for vaccines or whatever else you're doing, how do you connect people to those resources? Well, locator apps have sprung up for all sorts of things. And one of my favorites comes from New York City. Now they have a vaccine locator app that not only shows the public where they can find their nearest vaccination site, but the users can filter by the locations that have open appointments that are delivering particular vaccines on particular days. So you can really select what you need for your purposes. Now, we recognize that sometimes you need to take the resources to the people. Like you have to provide vaccines to homebound or maybe hard to reach populations. So I'm representing a part of that workflow in this graphic where we're showing how GIS can help to optimize routing for mobile vaccinators and help them better manage their time and their resources while also meeting patient preferences, kind of like the equity factors. You can match up routes to vaccinators with particular language capabilities or other things that people need. And you can also provide reliable visit time estimates. So certainly better than the cable company does. Now, finally, in this age of conflicting messages and misinformation, our trusted health organizations really need communication tools that are clear, that are engaging and reliable. So a lot of people are using ArcGIS Hub to keep the public informed. We have embedded maps and apps that can go into the hub that support that clear information delivery about a particular topic. So for coronavirus, we developed this coronavirus vaccine outreach hub solution. So this is just an example. It's a template, and it gives clear information about the vaccine process. But it's totally configurable if you want to change things, but it starts as a baseline. Now we had multiple apps in this hub site, but one of them was kind of early on in the vaccine distribution. It performed what I would call digital triage by helping residents figure out if they were eligible, if it was their phase of vaccine eligibility. Now, if somebody was eligible, then they went straight to one of those locator apps to find a vaccine provider near them. And then we also gave them an opportunity to share their vaccine story with the I Got Vaccinated story map. And I would suggest, if you like, you could take a picture or copy down the URL on this slide. Now, this I Got Vaccinated story map was intended to reduce vaccine hesitancy by highlighting community members who chose to be inoculated. And I certainly added my story right away. You can too. This is still open to everyone. It takes about 2 minutes. And together, I'm hoping that we can all continue to encourage people who are still on the fence to go and get their vaccine. And by the way, all of our applications are supported in dozens of languages, ensuring that everyone has the same opportunity to access the latest resources that would be available to them. Now, geography also supports another kind of communication as well. You can do very targeted messaging on important issues like vaccine confidence, or some are saying vaccine hesitancy. I guess it's a glass half full or half empty kind of conversation. But we are working, ESRI is working with the US CDC to combine all sorts of information, information on attitudes, on research data, lifestyle information, and even the channels through which people like to receive their information, so that we can create resonant messages and hopefully increase vaccine uptake And this is for COVID and actually for all vaccines. So honestly, I know this is just the tip of the iceberg. So much of pandemic response requires location awareness. And I know that this global pandemic story has so many tragedies, in fact, overwhelming numbers of tragedies. But I did want to point out that it also has its triumphs. These and many, many more innovations have happened in response to the pandemic. And it is my hope that they will be implemented and used forever on, right, to do better for health and public health. I think health and health IT has never been more important. And I will end almost with a shameless plug, but Novil wanted me to do it. So I've actually, I've written a book called Learning from COVID-19. It's part of the Applying GIS series. And you can get it on Amazon or Target or anywhere that you buy books. It'll be available on May 31st. And also, if you're interested in just trying out GIS and you want to start learning, we have a brand new curriculum available. It's totally free. It has trial licenses associated with it. So you can just, get your hands moving on the software and see how you like it. So with that, I want to thank you for your attention. Please feel free to follow me. I'm always posting messages about the newest innovations in GIS for health. And I'm going to now turn it over to Dr. Beardsley for her presentation.
Thanks so much, Este.
At the end, sorry, Karen.
That's okay. I'm always so impressed and overwhelmed by the amount of tools and resources and capabilities that there are. And I love the way you sort of said that, the pandemic is not a good thing, but there is some silver lining of what we've been able to, do as a result and pull together in this time. So that's great. So shall we just, Novil, I don't know if you wanted to do any transition, but I'm happy to just move straight into mine.
Just move on straight into your presentation. Please tell
Okay.
us about you more during your presentation. Thank you.
Okay. Please let me know if this is sharing correctly. Are you seeing my first slide?
Yes, we are seeing. Yes.
It is. Okay, so you can see the first slide. Great. Okay, well, great. Thank you so much. I'm going to take us a little bit backward. I'm going to talk, I call this presentation Back to the Basics, because I want to let people know a bit about how you can get started, how we teach GIS, or one way, how I teach GIS, I should say, and just some of my experience having been using ESRI products since 1989. So that's quite a long time. And so what I want to share with you, I'll be as brief as possible, because I think it's much more interesting to hear about these real applications and real world solutions. And of course, we want to launch the vaccine incentives story map. So, but bear with me, and I will start by just telling you a little bit about who I am and my background, so you know where I'm coming from. I started using, as I said, in 1989. I used this program called ARC Info. I happened to be in Kenya finishing up my Peace Corps service, and there was a need to have someone use GIS to estimate elephant populations. Well, I didn't really know anything about GIS. I didn't even know what it stood for, but I said yes. And I ended up working on a project, and that was my first GIS ever. And it was an amazing kind of program and project to be involved in. So I'm not going to really talk about that, but I just wanted to let you know that I sort of fell into GIS. Nobody knew what it was in 1989. So, and a little more about me, I was born and raised in California, but I've also spent some time living in New York. I also lived in South Dakota for a summer and worked at the Eros Data Center, which is one of the largest US-based place for satellite data. I also was, of course, a Peace Corps volunteer, as I said, in Kenya, where I was a math and science teacher in a rural village. And then I was a Fulbright scholar much later, much more recently, in Bhutan. So I set up GIS curriculum and taught at what's called the Royal Thimphu College in the capital city of Bhutan, which is a small country in the Himalaya mountains, sort of near Nepal, India, China, in that region. My degrees are in applied mathematics. That's my first degree. So I was a mathematician before I became a geographer. GIS kind of turned me over into geography. I've never looked back. I worked for 20 years in the Department of Environmental Science and Policy. And then more recently, after my experience in Bhutan, I changed, kind of switched careers a bit, and am now working in global affairs. So looking at global, I manage some global exchange programs, much like the Humphrey Fellowship Program, which is how, of course, I know Novil. And so I'll talk a little bit more about that as we go on. And so, yes, I've been the director of the Humphrey program since 2014. So I'm going to just start out with some of what I call my own GIS facts, because I think they're just little short snippets of information that maybe I think we all have some things that we think about GIS, and maybe it can help to sort of understand some of those things that are maybe opposite of what you would normally think about GIS. And then I'll go into just a tiny bit about GIS, and then also sort of the difference between ArcGIS Pro and ArcGIS Online, which we've been hearing a bit about. And then finally, I'm going to show some examples of uses of some of these tools that we've seen, not for public health per se, but in the global education setting, and also teaching. So one of my points here I want to make today is that you can get started using GIS, and it doesn't take you years and years to put together some of the things that you need today. Maybe somebody needs to mute. I'm hearing a little bit of background noise. Okay, and then of course, most importantly, some resources for how you can learn more and get started. And Este already shared a couple of those, and I'll give some more that you can use as a starting point. So here's mine, and these are just mine. These are not from anyone else's website. These are my top 10 facts about GIS. So hold on, and we'll get through 10 of them. Number one, GIS is used in every field. So you saw a lot of examples today that are around public health and COVID and disease. And
I don't think this is what I'm going to be doing. So.
Oh, okay. So maybe who's speaking can be muted. Okay. So anyway, GIS is used in every field you can possibly imagine. And it's not just about analytics. And you saw some of that in the previous presentation, right? It's about communications, and it's about collaboration. And I think this is something that's really evolved over the last couple of decades, where GIS used to be just something that you used to analyze spatial data. But now it's really about visualizing data, interacting with data, sharing data, collaborating with data. It does not require you to be a programmer. This is a super important thing for me. I used to be a programmer. I am not a programmer anymore. So the fact that it does not require code is really important. It does not necessarily have to be prohibitively expensive. People think I can't use GIS because it costs too much. ArcGIS Online has really brought GIS to everyone. And while there's in some cases maybe some costs, there's really no reason why you don't have to have tens of thousands of dollars in order to use GIS and these tools. So a lot of them are free, and some of them are very inexpensive. Okay. People really like to see things visually in maps rather than seeing a bunch of numbers and tables and spreadsheets. People like to see things and learn and understand the world through maps. And that's just an observation I think that I've had, and others as well over the years. GIS learning can happen at all speeds, meaning you can start slow or you can move really fast. It doesn't matter because there is so much to learn. You can never know everything there is to know about GIS. I was just commenting a couple of days ago when we met with Este, and we both still take online, we take courses, we learn, we try to pull, we're always learning. It's a lifelong learning thing. That said, you can do some very interesting and important things early, but there's constantly learning that can happen. And that's great. And the best way to learn GIS is to do GIS. So watching and watching someone else or seeing, looking at what someone else did is really great and helps, but really you just have to get in and do it. And the more mistakes you make, the faster you're going to learn. And the other thing I wanted to mention is data is so important. You heard that already, but it really is about the underlying data. I like to say, you've heard the term maybe garbage in, garbage out. If you have poor data, you're going to have, what you get out of it is not going to be of value. So the importance of data is really cannot be overemphasized. And then finally, no matter what, I think, working with spatial data is fun. It can be frustrating, it can be time consuming, but in the end, it really is enjoyable for pretty much everyone I know and talk to. Okay, so with that, those are my top 10 facts about GIS. I just wanted to go into a little bit about what is GIS. I think we all probably know this, but I grabbed this from ESRI's site, and I like this site because it just takes it through the very basics. And again, we're kind of starting at the basics here. So, GIS creates, manages, analyzes maps of all types, connects maps, integrates location data, all these various kinds of things. It helps people understand patterns, relationships, and it can lead to improved communication and efficiency, as well as better management and decision making. So those are just some of the key things that but that website's really important. And then I just want to share one of my, I have lots of slides teaching GIS. We're not going to do that today, short. I'm just going to stay very short. But I just wanted to mention that of all these components of GIS, the most important one is really the people. And this is a tool and a series of applications and things that can help us do our jobs better. And we make the decisions. We're the ones who pull everything together and create the visualizations. And it's a very creative process based on sound data, but really it's the people that really matter. And this is actually a shot of us from our GIS, a picture from our GIS lab at UC Davis. And these are some fellows from 2016, 2017. So I want to just clarify, make sure that it's clear to all of you, because I know some of you are new to GIS, that there's sort of this desktop GIS and then there's ArcGIS Online. ArcGIS Pro is sort of this software that goes on your computer. It's really good at deep analytical processing. It's where you work with your data. You really make things happen with your own data. But then, ArcGIS Online is a platform. It's web-based. It's just, you need a browser. That's really it. And everything you do in ArcGIS Online is processed through other servers. It's not on your computer. And also you can find a vast array of data resources on ArcGIS Online. So I'm going to focus the rest of the time on ArcGIS Online, but I wanted to just make this point. And again, I have the reference to this information here at the bottom of the page. And I also want to point out that for those of you that are Humphrey Fellows, that we do have graciously from ESRI, we have a Humphrey ArcGIS Online organizational account. It's at humphrey.max.arcgis.com. Any current Humphrey Fellow and alumni can get access to this account. All you have to do is email me your Gmail or long-term email address. Okay. So I want to just share now a couple of examples. So this one is one that I put together. This is just in my work. So I'm looking at UC Davis active agreements. You can filter. This is a dashboard, and you saw a lot of examples of dashboards before. So you can have lists of information. These all interact. You can sort of see where UC Davis is involved, has agreements of cooperation with other institutions globally through this sort of almost like a heat map or clustering sort of view of the data. And again, you can click on one of these, get a pop-up window and learn more about that. Another one would be for the Humphrey Fellowship Program. So we put together a survey in what's called Survey 123, put together a survey of top professional affiliations and local partnerships, and had the different campus coordinators fill that out for the last 5 years of ones that they these affiliations and partnerships that they thought were most valuable. And then that can be pulled, the data from that survey gets pulled into a dashboard. So this is a really common and simple thing to do. And then you have this view of that information, which again, this is just a picture, but you can interact with that data by clicking and navigating through the map, clicking on buttons, getting pop-up windows and that kind of thing. Here's just another one from the Humphrey Fellowship Program at UC Davis. This was created by our alumni, Adnan, and he keeps this going every year. He adds our new cohort of Humphrey Fellows. So this is our current cohort here. If you click on any one of these pictures, this is actually a story map. It's the older version of story maps. We call now story maps classic. There's ability to do this in the newer one as well. But this, you click on any one of these and it links to the person's profile. You can also go through the different tabs for the different years of Humphrey Fellows at UC Davis. Another example is another program that we run at UC Davis called the Mandela Washington Fellowship Program. And this again lets you interact and filter through different years, different countries, and then click on the information, resultant information here, and be able to link to profiles of those fellows. And you can also interact with the map, and everything again is connected. And the last example I want to give is there's a lot on this page, but I'm hoping we'll be providing a PDF of this so you can look at these things yourselves. But part of the teaching at UC Davis, we really want to focus on those sustainable development goals. And I've been able to incorporate that into some of my teaching. So I taught GIS at UC Davis in the summer of 2020 and 2021 during the pandemic. And my students, not only did they use ArcGIS Pro, but they also did a big project at the end. And they were able to put together, each of these is a story map. Each of them is a story map that the students put together to share the information that they came up with and their analysis and their results and their conclusions and their next steps. And they presented that in story map format. So story maps are a great teaching tool. This was all done in 6 weeks. So at the beginning of each of these programs, each student they were just learning GIS from scratch. So it can happen fairly quickly. And then I want to also mention in 2019, I've run a study abroad program back to the campus in Bhutan, where I was a Fulbright scholar. And in Bhutan, they focus on gross national happiness and various domains of that. And again, the students' projects revolved around those. And this is there's a link here to the story map about that program. And then the students each created a story map about their projects, and it all focused on Bhutan and used Bhutanese data, and then also centered on these domains of gross national happiness. So, you know, of these tools, as far as accessibility, there is always a 21-day free trial license that you can get to try out any of these tools, both ArcGIS Pro and online. I will say that a lot of universities and organizations have these tools already available. So for the Humphrey Fellows, for example, most of the universities where you are hosted have the ability for you to sign up to their organizational account. And oftentimes these are available through single sign-on and so on. ArcGIS Pro, you have to remember that the one that's on the desktop is only available on Windows-based computers, not Macintoshes. But ArcGIS Online really does not, as I said before, does not require software, and it's cloud-based. Then, you know, there are a lot of resources available for teaching you more about this. So I will just focus a moment on the Humphrey Fellowship Program, ArcGIS Online organization. And again, we currently have 103, I think, members, Humphrey Fellows who have signed up for this. And this is your kind of your starting point. You can actually get to all of these different applications that you've been hearing about: story maps, survey 123, dashboards, map viewers, and various other things through these 9 little dots that are on the top of the page when you get there. So that's one of the things I always like to share with people. It's so quick. You click on those 9 little dots and then you get that list of those applications and can go from there. How do you start learning? Well, I think it was mentioned before, but there's one of the best places I think is this learn.arcgis.com, which is now part of this hub. A hub is another sort of application that pulls things together. And if you go to new user, there's a lot of just great ways to start from the very beginning. And I also want to point out the Story Maps Gallery. I think there are millions of story maps out there. And again, this is then the lead up to the next and the final, what you've all been waiting for is the rollout of the vaccine incentive map, story map that you'll see next. But the gallery is a great place to see what others have put together, and there's stories about just about everything you can imagine. There was a wonderful story maps workshop at the Global Leadership Forum in Washington, D.C. in October. So many of you got started there, but it's always great to go and see what others have done and give you great ideas. And then I'll also mention the ESRI Training Academy, which again, once you have that online account, you have access to this ESRI Training Academy, which also has some great resources for learning and pathways for learning. I will also share the plug for Este's health information. Not her book, but I mean, I also give a plug for her book, and I can't wait to buy it and read it. This is available now, and I encourage all of you to go give this a look. There's a link to it on this presentation, which I believe Novil has put in the chat. So the great thing about this is it gives you some background information. So you pull together some of those foundational tools before you get into some of the more detailed and more specific information about health and public health and modernization and so on. All the way through data visualization and analysis, and then sharing, that communicating and sharing aspect. That's also so important. Okay, whoops. So with that, I will conclude and thank you for your time and listening. And I hope that gave a little bit more background. And with that, I'm going to go ahead and pass it. I'm going to stop my share. Well, you have my contact information here. Please feel free to reach out to me, especially if you want to be part of that Humphrey Fellowship organizational account, or any other questions you might have. So with that, I will stop my share and over to you, Novil.
Thank you so much, Dr. Karen. Yeah, can you see my screen now?
Yes.
Yes, thank you. So now, with those 2 great presentations on the use of spatial technology during the pandemic and the general uses as well as opportunities for learning and using GIS technology, let's now move on to the problem that we are trying to look at today. The problem or the issue that we are trying to look at is COVID-19 vaccine incentives. As you all know, the availability of COVID-19 vaccines was definitely a turning point in the global pandemic. So when you look at the data, we seem to be doing quite well. This map shows the share of people who received at least 1 dose of COVID-19 vaccines by February 14th. It looks quite good, probably, but there's definitely regional disparities. If you look at the African subcontinent, we have major vaccine issues. Look at this map. This shows the places where the world's unvaccinated people are by the same date. So we can see that we have vaccine access issues in some part of the world, but even when we have vaccines, there are big problems of vaccine acceptance or we have issues of vaccine hesitancy. So vaccine hesitancy is a big challenge that the public health professionals all over the world have to face. So we have to look at innovative ways of addressing this challenge. How do we motivate a person to take a vaccine? We have been taking vaccines for many decades. However, when the new vaccines comes for a new disease, there's a lot of misinformation, disinformation, a lot of mistrust, and people are very reluctant to taking vaccines. There are many models that have been used to explain new behaviors, new health behaviors, such as vaccine acceptance. You all know that there is the social ecological model, which tries to look at the individual, and then there's the interpersonal level, community level, organizational level, and policy and enabling environmental level. How these different factors would determine if a person is going to accept vaccines or not. So some of the vaccine incentives could be looked at from this model's point of view. Another model that is trying to explain people's behavior change, such as acceptance of vaccines, is the trans-theoretical model proposed by Wijesekara and colleagues. So they say that people go into different stages when they have to adopt a new behavior. At some stage, they are not ready. They are in pre-contemplation. Then they may be getting ready where they're in contemplation, and so on and so forth. So vaccine incentives could probably help them to move from one stage to the other. Another very important model that is often used in explaining people's health behaviors is the health belief model, where a number of factors related to the new behavior contribute to the adoption of the desired behavior. So people try to weigh the perceived risk, severity, benefits, and barriers, as well as demographic, psychological factors in making decisions about their own health. And there are some cues that help them to take action. So probably vaccine incentive could be a cue, or probably a possible perceived benefit when people make the vaccine decisions. In summary, vaccine incentives could help to tilt the weighing inside a person's mind about accepting vaccines. So for this particular activity, or for this small project or the initiative, we thought COVID-19 vaccine incentive or a reward is something desirable provided to a person to stimulate acceptance of COVID-19 vaccines. Then COVID-19 vaccine disincentive was coined or termed as a punishment, something that is undesirable, that a person is subjected to for not accepting COVID-19 vaccines. Both are with the same objective. We want people to adopt vaccines. So we go back to our old idea of carrots versus sticks. So incentives are probably carrots and disincentives are stick. What works for them? Well, some people like carrots and some people prefer sticks. Some people don't care for either of them, right? That is the challenge that we are facing as public health professionals. So during this project called the Global Observatory of COVID-19 Vaccine Incentives, we abbreviated it as GOCOVI, we have two objectives. The first objective is to collect, curate, and share COVID-19 vaccine incentives and disincentives across the world. The second objective was to collect and share research on the effectiveness of COVID-19 vaccine incentives. How did we do that? We reviewed online media reports on COVID-19 vaccine incentives until February 2020. We also reviewed published research on COVID-19 vaccine incentives for the same period. We used a tool called the story maps to present these findings. So story map, as you may have heard, is one of the applications that is available in the ArcGIS organization. So I was very fortunate to have access to the Humphrey Fellows ArcGIS organization, as well as a very interesting training that I've received from Dr. Karan, as well as the Story Maps developer team in Washington, DC during the Humphrey Global Leadership Forum. And that is the place where I got this idea, and I was able to implement this project as a part of that. So I would like to acknowledge that support now. Now let me go and take you to the the COVID-19 Observatory, Vaccine Incentives Observatory. Give me a second. Right. Can you see my observatory now? The observatory slide screen?
Yes, yes.
Yes. Okay, thank you. Thank you so much. Yeah, so this is like we are scanning the whole world, like a big satellite would be doing, or big telescope would be doing, to look for COVID-19 vaccine or incentives in the world. So here we have broadly categorized incentives, but we looked at both incentives as well as disincentives. So if you want to navigate in the story map, we have had some tabs here. So you can move on to any of those things to go into the different sections. So most of this work was very qualitative in nature. So we had a very interesting way of presenting our findings. So first, let's look at the incentives. So these are different things that all over the world that has been provided to motivate people to take vaccines. Would you like to name some of them by unmuting your mic?
Donuts.
Donuts, yes, thank you. Anything else?
Ice cream, pizza.
Car,
Ice cream for Canada, right?
money.
Yes. And there's a cow as well, and eggs. And what about this? This is actually, I couldn't find a clip art of a joint. Actually, in some parts, they gave weed cigarette to promote. And of course, they gave gun license. I have a public health caution, as mentioned by Dr. Este. These are not good public health incentives, but just with that disclaimer that weed is not good for your health as far as what I believe, and guns can kill people. But these were all incentives given in different parts of the world. There were blenders, cars, gift cards, university entrance, scholarship to universities, schools, trucks, eggs. It's amazing how we are motivated by different things just to improve or protect our own health. Let's look at the disincentives. Yeah, these are very well known. One thing that we did not add here are global travel restrictions. So we thought it's very global thing, but we acknowledge them. Okay, sometimes you don't get access to schools, to university, to workplace, and sometimes you will be fined. People would go, some law enforcement or public health officials would have some control over you. And in some parts of Pakistan, they threaten disconnecting your mobile phones if you don't get the vaccination. So this is a very interesting You can just move these around and, have a look at them. I love that. Okay, now let's look at the first part of the observatory. So in this part, what we did was we gathered all the vaccine incentives across the world, which are documented, of course, in English, except for in few countries where my Humphrey fellow colleagues have helped me to, get from their local languages. So, so you can explore. I'm not going to explain this. I'm just giving you a tour of the observatory. This is your observatory. Please use this data. We are recording history in the public health, and then we won't have to reinvent the wheel when the next pandemic happens. So you can just click on one of those things, and so you can, the location will be shown. And the beauty of the story maps is you can actually play whatever the information that is there. Of course, Google has their ads. Apologies about that. But you can have
those who get vaccinated could win some major prizes, like a chance to win a college scholarship.
Okay, so likewise, we could go down. Now, this is in Philippines, you can win a cow. You can get a house if you get the vaccines. So in some places, like this is in San Francisco, New York, Ohio, New Jersey, there were college scholarships were given. You can see the governor eating a donut, the number of states. So these are from some other countries than the US, but you can see definitely the US, the map is quite densely populated with incentives, right, reflecting the hesitancy. I think hesitancy is a still problem in some parts of the world, but the access is competing over that. So without making vaccines available, people won't go and make incentives. But so here are some examples. So this app has made it very easy for anybody who wants to research to go and have a look at these incentives, because we have been able to get them all together and put in one place to make things easier. So here are the different incentives that are given. So you can see this is in Thailand. They gave a cow, a free cow if you want to get it. And this is the my favorite one, where they at DC, they gave marijuana. They gave joints for jabs. So quite interesting, quite controversial, but probably there's a big story behind that. Of course, some public health professional would have decided this. We really should look at what is their thinking and what was the target group. And probably these were the best way that they thought would reach out to the particular target group, right? So, so it's really amazing how many things that public health officials have tried to get people vaccinated, right? So we are talking about their own health, but it has not been an easy journey. So that is the first thing that I want to share. So then what we did was, this is very qualitative analysis we have done, or rather qualitative data collection. However, we try to look at some quantitative aspects. So what we did was we created one data card for each vaccine incentive. So it was in one media report. Sometimes you have 1 or 2 or 3 vaccine incentives, but we added one for each of them. So the number of vaccine incentive data cards are not more than the number of media reports. Like sometimes if the same media report is covering the same incentive in the same location, we removed that. So when we did that, we found that 113 types of things. Isn't it amazing? Like 113 type of things can be used to stimulate a person to take a vaccine, which is for their own health. This is the real learning that we have to know and learn during the pandemic about human behavior in relation to health. Then we looked at, categorized them as positive or rewards, right? Most of them are positive, but there were some negative rewards as well. There were two types of incentives. Some incentives were conditional and some incentives were unconditional. So most of them were conditional. Unconditional means no matter what, if you get a vaccine, you will get $100. Unconditional means it's quite different. Okay, you will win a house, but you get a chance to win a house. So it's rather conditional. So whenever you have these massive prizes, huge prizes, the houses or scholarships or vehicles, these are kind of conditional. Then when we looked at the incentive types, we could categorize them as monetary as well as non-monetary. So monetary means it was direct cash or money was transferred to their bank accounts or sometimes mobile cash, something like that. But non-monetary means it's something tangible, something physical that was given to them. Then we looked at type of non-monetary benefits. So we could see that most of them were for leisure and entertainment. Probably people were really sick of being inside houses during the pandemic. So they really wanted to go out. So if you want to go out, get a free ticket to a park or free pass to some interesting place, they were motivated. Then we had gift cards. I think this was probably due to the ease of administering them. There were some food and beverages. Educational opportunities were big motivation. Probably this was targeting younger population. Vehicles, ornamental jewelry, even kitchen utensils, probably targeting the females. This is probably in India, where they gave a blender and a hairpin to stimulate vaccine acceptance. Then we looked at the types of disincentives. So most of them have been prevention of entry into places. But there was one occasion where as I mentioned to you earlier, in Pakistan, they actually used the threat. They did not really disconnect people's mobile phones, but they said, if you don't get vaccinated, we are going to disconnect your mobile phone connection. So these are some amazing things that we came out of these incentives, but these, we know the restrictions. I mean, these were just collected information. And so by no way we could use this for any statistical purposes or predicting anything. They are very crude measures, but I mean, these things that came out of mostly a qualitative analysis could still be useful. Okay, now let's look at the next part. It is about evidence. Okay, we are in the era of evidence-based medicine. Is there any rationale for what we are doing? What we did was we went and looked at different researches done on the effectiveness of COVID-19 vaccine acceptance. So the green arrows or the upward arrows in this map shows different researches that have been done on effectiveness of COVID-19 vaccine incentives. So at the initial phases, they were basically reviews of past vaccine campaigns because we didn't have any data. But as the time goes on, more and more interventional type of studies or analytical studies came in. So we have put all this information, the researchers that we could find on COVID-19 vaccine incentives. Then there were studies which proved that COVID-19 vaccine incentives do not increase vaccine acceptance. So the academic community or the research was kind of split on the topic, right? Some said it does not increase. So we have documented them as well. So objective of the observatory is to give you opportunity to observe, not to make any decisions, but we support that this information that we pull out from different parts of the world depicting human behavior as well as the public health response could help us to answer these questions effectively, not only during this pandemic, but also in future pandemics as well as in crisis that we might face. The next part is that we went in about the evidence, we created the timeline. So you can see in January 16, very early, they review existing information and they said it could be. So again, green means the incentive is in favor of vaccine promotion, increasing vaccine acceptance, and yellow means it's in favor, it's against the use of incentives. It says that they really don't work. So we can see that the evidence is kind of split, and it's very difficult to do a plan kind of studies for large areas, but some areas for state level, they have analyzed the data. And so this evidence is there. And there are some other information. These are not research studies, but opinion pieces that people have written on different vaccine incentives and whether they should be useful, its legal aspects and ethical dimensions, etc. So last but not least, this is your observatory. So this is not something that for somebody else, but this is for you. So you can use the two forms here to provide information that you find. If you find any vaccine incentive that is not reported on the this observatory, you can use these two forms to provide us more details. So again, I would love to thank all those who supported in this small initiative that I did during my Humphrey Fellowship Program. I'm really grateful for the Hubert Humphrey Fellowship Program for giving me the opportunity to be at this amazing, prestigious place of the Hubert Department of Global Health at the Rollins School of Public Health at the Emory University. So it really helps me to look at this from a global perspective. And also I'm really grateful for my colleagues, my boss and all the colleagues who helped me to come here and pursue this professional development program from the Disaster Preparedness and Response Division of the Ministry of Health. And I love to thank the advice given to Dr. Karen for organizing this Humphrey Story Map workshop, as well as the Humphrey organization for the Humphrey Fellowship. It's an amazing tool and it's very, very helpful for all of us. And also a very special thank you to the Humphrey Story Map team who trained us on this. And I am really, really grateful for Dr. Este Geraghty, who is the Chief Medical Officer, and she's extremely busy person. She does amazing work across the world. And she's one of the most sought after, or maybe the most sought after person in GIS, health GIS in the whole world. So her support and mentorship was really, really appreciated. And I would like to thank Ms. Hasuri Patirana from Sri Lanka, who helped me with the data collection. And we are grateful to all the original sources of data. A special notion is needed about the National Governors Association of USA. So they compiled a very elaborate and detailed list of vaccine incentives by different states. So this was the basis for most of the vaccine incentives in the US. And I have my two Humphrey Fellows, Pavle from Serbia and Elisaveta from Bulgaria, who has already contributed, and I'm sure the other fellows are on the way of submitting the information to be portrayed here, and also to Dr. Lahiru from the disaster unit for providing this information on the Sri Lankan context. So I'm so thankful for listening to you, to me for all this time, and I will end my presentation, and now I will put the link to the this COVID-19 vaccine observatory in the chat box. In the meantime, I would love to invite Dr. Karen Beardsley to moderate the question and answer session. Thank you.
Thank you so much, Novil. That was fantastic. So wonderful what you pulled together, and wow, I love it. Let me go ahead, and as I said, if any of you have any questions or even comments or something you want to say, feel free to raise your hand in Zoom, or just type your question. Excuse me, type your question in the chat, and I'll make sure that we have everyone's question or comment heard. So, you just put the URL to the story map in the chat. Great, thank you. There must be some questions out there, I'm sure. Well, I'll start. I wanted to know how exactly did you find out about all of these? Was it a lot of word of mouth, or did you you search the internet for incentives? And I mean, how do you find out that a cow is being given as an incentive in Thailand? I mean, that's fascinating. But how did you find out about these?
Yeah, so thank you very much. Yes, this powers the show of qualitative information, and there's so much information out there that we public health professionals sometimes don't consider information. For us, it's a news. So I think if something goes in a newspaper, something that a newspaper editor thinks it should go take some space in their newspaper or online magazine or newspaper, it's something really important from them. So we started off with actually very grateful to the Governors Association. When I saw the list that they have prepared, it's very elaborate. And at the initial stages, they were updating it very, very frequently. And they had the very interesting notion, we are updating this, but we still don't know whether they are working or not. So that was the interesting thing. So they just started gathering the information. And then in some of the news reports, for example, from BBC or CNN, they were mentioning about these cows and eggs when they were mentioning about the incentives in the USA. So what I did was I went back to the original country newspapers and website and searched. And the other thing was mostly by online searches. And then some of my colleagues referred some of the incentives. For example, Pavle and Elizaveta referred me about some interesting things that's happening in their country. So, but majority were online, based on Google searches and other search.
Yeah, great. I imagine there's way more out there that you don't know about yet, which is why it's really nice there's a form that people can submit what they know about, right? And then yeah, from there. So Jennifer has a question. Do you have an overall conclusion from your research about incentives versus disincentives effectiveness? Because I guess the question is it more effective to have incentives or disincentives?
Yeah, thank you. Thank you very much, Jennifer. I think my personal opinion, looking at all these things, not necessarily the pieces of published research, because they are very different in research design and their methodologies and how they approach the problem. But looking at the whole things, I think vaccine incentives do work. However, that is a very dangerous contract that we are coming with our communities. Because, okay, people might ask at a certain stage, okay, to get my child immunized fully, how much are we going to pay? Okay, one COVID-19, you pay me $100, as it happened in Fulton County here. Okay, I'm going to give my child 8 doses. How much are you going to pay? I mean, I think that's a big public health risk. So it works, but in the short term. So I think it's okay to do that. We are during a public health pandemic, right? We just have to get this mess cleared out. But in the long run, one's own health, the health promotion, taking responsibility for one's own health, those things really come into play, because public health professionals will not be able to look after the community in this much of vigor and intensity in a long.
Because I think what you're saying, Novil, is so interesting, and maybe something that you'll want to comment back on as well. You know, I'm thinking about incentives as you've presented, and I think you make a really spectacular point about that maybe it's not the best public health thing to always have to be rewarded to do the right thing. I mean, we always have said, at least in my public health career, that we make the right thing the easy thing to do. So you want to make things available, but you don't want to promote having to be rewarded just to do that right thing. But I thought your comment about making it short term was actually a really great idea, because I think that vaccination, especially for a pandemic in particular, I don't know if I would think this applies to all vaccinations, but having it as a campaign and putting a time limit on, you'll get an incentive if you do it within this time period, creates a sense of urgency that might help actually get a campaign moving more quickly. And I also think, you know, there's sort of maybe a bad thing about incentives related to feeling like public health is desperate, so they're going to offer you a prize. And that's what I sort of thought when I first heard that they were doing like $1 million lottery in the US, in Ohio. And I thought, oh, that just sounds too desperate rather than a true incentive. On the other side, and the thing that maybe you would like to comment on, I think that even the small incentives, or the incentives that don't feel like public health incentives, like cigarettes and guns and the like, I think there might be something that would be very hard to measure about that our trusted brands are coming out and showing support for the vaccine, and that it creates a sense of unity, that we're all in this together, we're all going to contribute to get our populations healthier. And I don't know how we measure that, but I think having all of these many incentive programs just kind of shows everybody's all in. And I think that could really help with some of the mistrust and the siloing that goes on during the pandemic. So I wonder if you've thought about it from that perspective as well.
So Novil, I think that the question was back to you regarding your thoughts on what Este just said.
Dr. Este, can you please repeat the last part? I was responding to the chat, so I missed it actually.
I was wondering if you thought that, well, I don't know if it's measurable, but if you think that there is a benefit to incentives that goes beyond the incentive itself, which is the value of having trusted brands come out in support of vaccination, and the sense of unity that populations may feel when many of our brands, despite whatever they're offering, are saying we're pitching in to support this program.
Exactly. I totally agree with that. For example, sometimes there were like big supermarket chains offered gift cards, or they gave reductions or big, incentives. But it was really good that they all came and pitched for the same idea. So it's not that, some fight that public health professionals are doing, it shows solidarity, it shows cohesion. We all come and helping. So yes, definitely. I think one way to do that probably is like we could go back to these same incentives, especially those given by corporates, and try to dig into what made them to do these decisions, take these decisions, and what they thought about them in the first place. But the important point from public health point of view is that we should be ready to get all these stakeholders engaged in our ecosystem when we are responding to a public health emergency. So what happens usually is we are still in our silos of about 50 years ago. And we try to go a journey that is not shared. So that is a big obstacle that I think is facing public health in the whole world when it comes to fighting the pandemic. So getting these other stakeholders coming, because everybody wants to help, I think, in the pandemic. So as far as their commercial interests don't come into a big conflict of interest, I think it's a good idea, and we definitely should go and measure that. Yes, thank you.
Can I be controversial?
Yes.
So I will. I thought you'd say yes. So I want to talk about a disincentive that I've heard about. I did not see it on your map, but it's been mentioned many times in the US news, and I think it has to do with significant pandemic fatigue. But there are healthcare providers out there who want to not treat unvaccinated patients that have COVID. That certainly would be a potential disincentive. And I think that's a slippery slope, right? I mean, I think many people would agree that that's a real problem. And you start judging who you're going to treat and not treat by their behaviors. I mean, we're taught in medicine, you take care of everybody. But I think there may be some other kinds of healthcare disincentives. What I've heard that I think is potentially fair, but I'm looking for your comment on this, is from the health insurance point of view, that yes, you will be treated and taken care of if you're not vaccinated, provided you can be vaccinated and you don't have a condition that means you couldn't. But your care costs more, or you have to contribute a higher deductible if you have related issues to COVID and chose not to be vaccinated. I don't know, those are pretty hefty consequences, but they are being discussed. What are your thoughts?
Yeah, I think that is really a good way of pushing people to get vaccinated. But then comes the ethical dimensions to that. Now, I mean, you're paying for a service, right? I mean, you are making a contract with somebody to provide you services. And then how ethical is it to be conditional? That is one argument that I would have against that. On the other hand, what some people are discussing whether they could reduce the premium if you are vaccinated, right? If you're unvaccinated, it can work both ways. For example, making it as an incentive as well as a disincentive. I think all these things these are, I think, except for it's a house or a car, or college scholarship, which is very expensive probably. People are by giving incentives or incentives, we are communicating risk to the community. It's just, I think it's a risk communication tool, which is kind of very powerful. And on the other hand, if you go and see at the general industries or in the commercial sector, incentives are quite common, and we fall for them. If you buy one, we give another one. Or if you buy this before this particular date, you get 50% discount or something like that. It can happen, right? So I think it's really, especially in parts of the world where insurance really is a critical factor in healthcare, I think it can be done. But on the other hand, people could turn it the other way around. Okay, one insurance company would say, if you are not vaccinated, we would increase your premium. What if another company comes and say, no need to get vaccinated, we will give you the same coverage, probably at the same cost. So that could backfire. So then if we have to introduce something like that, the importance of coalitions. I mean, getting together, everybody getting together. So everybody comes together and decide collectively and do that. It would be really useful.
Yeah, and I think, you know, in the chat, Este's comment is interesting. What is the size of the incentive? You know, does that matter? Does it make a difference? And you know, my experience with vaccine hesitancy has been that a lot of people that have that hesitancy, there's nothing that's going to change their mind. At least that I've tried very, very intelligent people who are my friends from college who know better. You know, they have misinformation and they are trying, you know, and how do you get beyond that? And an incentive is not going to do that. You know, I feel sometimes it's hard to know what will make a difference.
Karen, I think first that one interesting point that you make is just that I anyway, and I think this is aligned with the CDC perspective. I don't think of the vaccine hesitant population as the ones that will never get the vaccine. I think of those as the anti-vaccination group. And there is a group that we call the movable middle. They have their reasons, they're unsure, but they're not forever against vaccines. And this is the group, we're not targeting the anti-vaxxers in our conversations because they are immovable. and right. The ones that we really want to influence are the ones that maybe have strong fears or concerns, but they can actually be spoken to and delivered messages and potentially satisfy whatever it is that is their concern to move in a different direction. So I would say that, and I know that Novil has some comment, but thinking about the size of the incentive, I wonder, and I don't know if this is true, if it mimics in a way I think back to California and the great work that California did with smoking cessation. And part of the way that was done was with increasing tobacco taxes and then all of the commercials. But I also know from the mathematical work that many did that there is a marginal return on increasing taxes. So you can't continue to do it and get to the last group and finally turn them into non-smokers. It doesn't work that way. There is a certain amount that is ideal that will adjust the movable middle. And so I just was wondering, does that translate to the positive? Is there a size of incentive that is enough, but not too much? Public health has limited resources. If they were the ones who had to institute these incentives. So what do you think, Novil? Is there a proper sized incentive for vaccination?
Yeah, that's a very interesting point. So basically, as I mentioned earlier, the large incentives are basically most of the time conditional. That means you are giving something large, but actually your chances of getting it is really, really low. So I think a person would rather know that, because we all have bought lotteries and very rarely we became millionaires by buying a lottery, right? So probably that process goes inside people's minds. So probably very large incentives would probably have an effect of probably buying a lottery. Everybody knows that, where large number of people are going to get vaccinated. So I run a chance of winning it and it's very low. Whereas the small incentives, very small incentives, I would say they're very symbolic, right? I mean, I don't think a person who is not willing to take vaccines would take a vaccine because you offer a donut. Yeah, they would enjoy the donut as well. So when the vaccine incentive is too small, probably it becomes not very influential in the behavior process. But I think the important thing is whether that really helps the person to get the vaccine by getting this incentive. For example, if somebody who is, finding difficulty of finding their daily wage or getting the daily bread, So if you make a sufficient contribution where somebody goes to vaccination, and that cost could be covered with that kind of a really tangible middle amount, I would say would be the proper estimate for a conditional, unconditional incentive. So conditional incentives are really, they look big, but when you divided it by the number of people, actually we are investing very little. And also, I really agree with you with your idea about the smoking cessation. This is the same model that was used, when we were trying to push people in towards vaccine, tobacco prevention or smoking cessation. So important thing is, as you very correctly mentioned, some people are not ready to take vaccines at all. For example, these may be the vaccine anti-vaxxers probably, and some are people who are not got enough information. Some people would be getting ready, they're in contemplation, and some would be in preparation, or they are already ready to vaccine. So if you just say, okay, we are giving $100, probably those are already ready would just go and get it faster. Or we may be able to move some people who are getting ready or in contemplation to move into ready category. But that is very important, because we can't wait eternally to get people to get vaccinated. This is time sensitive, right? We want this to happen within a very given time period. So I think my idea is that unconditional, moderate amount of incentives that can serve a particular purpose would help. But I think the donuts and very small things are not incentives, they're just thank you cards. Just say thank you for getting vaccine, something. So it conveys a message like that. But say if you get some monetary benefit, or you get something really tangible to take home and can use for the rest of the life, I think that kind of a thing would probably help more. Yeah.
I agree with you theoretically, although I'm often swayed by a donut.
Yes.
Do we have any questions or comments from others? If you've been sitting there waiting to ask your question or make a comment, this is a great time to do it. I know we've had a lot of people here for the entire session, and it's great that you're here, and we really want to hear from you.
If you don't mind, I really want to put Professor Indika Karunatilaka on the spotlight, who is a professor of medical education from the Faculty of Medicine, University of Colombo, where my alma mater. And but the problem is he's having some connection problems. Would you like to make some comments, sir, if you don't mind, about this as well as GIS? Because I'm very keen on getting GIS education in medical and medical curricula. So Professor Indika Karunatilaka has been a pioneer in the medical education in the country. So I would love to listen to you, sir.
Thank you, Novil. Yeah, sorry about my connection at the moment. The sounds may not be very clear. Yeah, it's very interesting, the range of incentives that you have described, and some very interesting and very innovative as well. Now, I was just wondering about our Sri Lankan experience. We are even being a middle income country which has made several achievements in public health, and related to vaccination and immunization. Sri Lanka has a very long history, about 40 years of experience, and actually Sri Lankans didn't really needed incentives for vaccination. It was there basically. I mean, the childhood and the maternal and child health, the vaccination, immunization was there, and immunization rates were actually very high, in high 90s. It has been like that. But after COVID, then there was some interesting phenomena, like initially there was a lot of interest about getting the vaccine, but later there was some hesitancy coming in. At the moment, we are facing challenges in giving the booster dose, and even now only just 40% of the target population covered. So there may be a lot more complex reasons for this vaccine hesitancy, especially in a country that has a long history and tradition for immunization and vaccination. So we might have to go deeper into those possible reasons. For example, there were some movement or some trend towards misinformation and wrong information basically propagated, even with the blessings with the administrative levels due to different political reasons, so on and so forth. So the reasons may be very complex, but it's rather concerned for Sri Lanka because we haven't been able to reach the levels that we have been expecting. Yeah. Regarding GIS, I think there are a lot of sophisticated technology that were described today, and it would be very useful if we can employ this in our settings as well. At the moment, we are basically trying to utilize the simple strategies. For example, at the moment, we are doing an entirely voluntary-based telemedicine service to support the patients, to give the simple advices to the patients for the home management, and it has been proven effective. And there also we are using the caller identification and the caller locations to come out with GIS maps, and it gives us reasonable information about the spread of the epidemic, so on and so forth. So a lot of things are happening, and I think there are a lot of positive things that we can take from this discussion. Thank you.
Much, Professor Karunatilaka, for joining us and for those very interesting ideas. So there's another question here. From Dr. Este, should conditional incentives be applied only at the end of the full vaccination, including boosters, or offering sequentially increasing incentives until the course is complete? I think the problem is COVID-19 is evolving. Like when we got at the initial stages, we said, okay, somebody get 2 doses of vaccines, or whatever the number of vaccines that we get, then you are done. And then we probably gave them an incentive. And now we are getting into the booster doses. So it's kind of evolving. And what is needed for us is to get people on board as early as possible. So people are have very short-term memory when it comes to their health-changing behavior. So I think every time you do something good, you have to say, you did well, and we give you an incentive. So probably I think if we can actually give incentive at the end of every vaccination or every milestone reached, for example, you get both the doses, or that would be a better option, because we are not sure about the future. You know, we might say, okay, next year also you have to get another booster dose. So so that's what I would like to say. You have a similar ideas or anything different, Dr. Este?
I guess I think there is a practical aspect to sequential incentives, just because I'm aware of the numbers. In the US, for example, we have in the low 70% range people who are eligible who've received at least 1 vaccine dose, which is highly incomplete and, you know, I'm tempted to say irrelevant, but I won't say irrelevant, but, you know, it's not complete. So the effectiveness cannot be shown, and it doesn't protect populations. It does not go very well toward herd immunity. And so, so how do we get people to complete their vaccinations? And fewer than 50% of those eligible for boosters have received them in the US. This is really problematic. So I'm just wondering, how do we get there? And can incentives be one of those directions? So yeah, I think I'm very well aligned with your thinking on this, but I see the problem. And then I think about technology systems, and it's difficult enough to track and prove people have completed their full vaccination course, much less try to incentivize them at every step. I mean, we don't have the best systems for tracking that and providing those incentives. Plus, many of the incentives are not through public health or government organizations. They're independent of that.
And the ideal situation, of course, where we are not living in that situation, is that we don't have to give any incentives. You know, I think we really have to redefine the way we define health literacy. People knowing about diseases and their transmission does not mean that they're thinking in the healthy behavior. We know this over smoking cessation or lifestyle modification, stress. We know the whole story, but I think what we perceive as health literacy has big flaws. And we need better measurements to measure people's health seeking or health decision making process. You know, health literacy, and you know, people seem to be very educated, but then they are equally, their process really goes and stuck them in their behavior. And also, looking back at this, the model that or rather the trans-theoretical model provided by Prochaska and De Clemente, argues that why our intervention programs usually fail is that we don't target our messages to that individual stage of behavior. I think that is true because we are having a blanket message to the whole community. So if we can categorize our community as to where they are in their stages of behavior and use the strategic communication to address that particular stage. This is not a demographic or social group, but with regards to people's behavior, if we can address that and have messages, I think that could be very useful, because they are if you look detail at this model, they're talking about 10 processes, behavior processes and cognitive processes that goes inside people's behavior. So we have to address those. So I don't know whether we have been able to tap that as public health or health professionals in general. So if we did that, probably we wouldn't have been able to do this. So probably this is a whole mistake that we are doing by giving incentives.
I really resonate with your remark about meeting people where they are. It's so important. It is, on the behavioral health side of things, equivalent and part of, in my opinion, personalized medicine, which has been touted for quite some time. But I would also just note that that's exactly the concept of studying geography and using GIS, is that while in the health behavior change model, the trans-theoretical model, you meet people at the stage where they are, you also recognize that people in different contexts, different geographies, also have different circumstances, and that's why understanding that geography and that context makes a difference. So I think one of the benefits of all the different kinds of technologies and advanced thinking that we have is that we're learning how to take these really finely targeted messages and themes to people in a way that resonates the most with them. So being personalized with, billions of population, we need technology to do that. And so it's just fascinating what you said, and really works for me.
Thank you. Thank you so much. There's a question from Alison Dover. She says that, is there any plans to share the story map widely, either with the public health officials or just more broadly with the general public? Definitely yes. So we would try our best to share it with different audiences, both as contributors. This is the observatory. It is a public observatory. I mean, it's for the people to come and put out their incentives and their research and use this for their own research. as well as use them for their decision-making behavior. So some of the bucket list that I have is I want to reach out to the NACHO, the National Association of County and State Health Officials. I'm going to write an email and invite them to go and have a look at it, and maybe request them to share it with the public health officials so they can see whether their incentive is there or not, or rather use these incentives to discuss that. Yeah, so we will disseminate this with our whatever the resources we have, our social media and other networks. And if there's any opportunity where you think is appropriate for us to come and give a brief presentation or share this story map by email or any lists serve or whatever, we would be more than happy to do that. Thank you very much for that very kind remark.
And I know we're coming up on the end of the hour, and I want to be able to pass the last word to you, Novil, but I did want to say a couple of things, which is, first of all, thank you, Novil, because I know you'll be the last one to thank yourself. So I want to make sure to thank you for really pulling all of this together, for your great work. And I know there's so much more to come. Sorry, my internet is being a little bit flaky. Okay, now I'm back. I also want to make sure to thank, I know Allison Dower wrote in, she works for the Department of State and the Bureau of Education and Cultural Affairs. And really both ECA and IIE have been really instrumental in having this ESRI and Humphrey relationship come together. So it's wonderful to see this happen. I know there's more to come. I just want to thank them, and I want to thank the last thing I want to do is thank ESRI for they donated the ArcGIS online platform for Humphrey. So that's a wonderful resource, and we really hope to keep bringing important information like this available and shared. Some of the great work that the Humphrey Fellows are doing. So again, thank you so much. So back over to you, Novil.
Thank you so much. I think even though we started in Sri Lankan time, 5 minutes later, we have to finish in US time exactly at 1 p.m. because we are in two different parts of the world. And some people, even in Sri Lanka, they have to go back to sleep, and over the West Coast, you are just starting the day. So thank you very much, Dr. Este Geraghty from ESRI for providing us this opportunity and speaking to us on this day, despite your busy schedule. Thank you very much, Dr. Karen Beardsley, and all the participants who came here on behalf of IEE and Department of State. We have many universities, if you really compile, be here from this part of the world to the other. So I'm so happy about that. Thank you very much. And I have shared the story map. Please feel free to contact me. With that, I would conclude this meeting. Thank you so much.